So it's a great pleasure to have Anindya Ghose. We had him scheduled last year, and COVID got in the way of that. And for those who know him, he's an amazing researcher with just an extraordinary breadth of topics that just push the frontier on multiple dimensions. And he's been doing it. The thing that's amazing, I always find, is he's been doing it for years. Just amazing. There are people who have one hit, but to have as many hits as Anindya, it's just unbelievable. So it's a great pleasure to have you, and look forward to hearing you this time. Take it away.
All right, thanks, Shane. Thanks for the very kind words. I'll try my best to live up to it. So thanks again for the invitation. Like I said, it would have been great to meet in the real world, but I'll take this opportunity to get some feedback and comments from you guys on some very early work we are doing. We're excited about what we've seen so far and look forward to any thoughts that you all have. And I see many familiar faces. Hi, everyone. Thanks for joining. This is essentially, the background is, we've been thinking for a while about this sort of a non-marketing, non-advertising aspect of mobile. So in my past work that some of you might have come across, I've been very intrigued by advertising and marketing on mobile devices. And, having, crossed over that, it occurred to me that maybe it's time for us to start thinking about a more, policy or a more, maybe a non-commercial aspect of mobile. And, mobile health stood out as something that is worth investigating. So for those of us for whom, this is not super familiar, basically, the mobile health is essentially an ecosystem that is a combination of mobile computing and medical sensors, various mobile apps, and as you may have seen, it's actually disrupting the ecosystem quite a bit, from transitioning from a reactive to a proactive system. It's also encouraging individuals who adopt these mobile health technologies like wearable devices to get into this quantified self notion, this idea that individuals can engage in self-tracking of their physiological, behavioral, and biological information. So as adoption and usage has started to pick up, we also start seeing some broader industry trends, some well-known companies like Google acquiring Fitbit a few months back, and the mobile health monitoring platform called Synosys. Synosys uses enhanced cameras and accelerometers and microphones in today's smartphones. So till date, I would say that the deployment of mobile health solution is facilitating the capturing, integration, the analysis of this very critical information about patient behavioral and biological symptoms, along with information between care providers and the healthcare system. Okay? One particular area that we are interested in is looking at chronic diseases, like diabetes, glucose, hemoglobin, blood pressure, etc. So this paper is going to be largely about these kind of chronic diseases, and I'll sort of focus primarily on diabetes, glucose people who have lower problematic glucose levels. Okay, so now so the motivation, like I said, is look, although mobile health applications have the potential to perform this real-time tracking of vital stats and medical conditions to facilitate this kind of disease management, they also have some sort of challenges which are important to keep in mind. Okay, and the challenges often come from the following sets of issues. First of all, again, even though they can facilitate this easy medical communication intervention, we have seen that frequent interventions might lead to some sort of annoyance or habituation. We've also seen that increased information capabilities that these wearable technologies provide can lead to potential information overload due to this cognitive constraints. We've also seen that if there's increased pervasiveness of personal behavioral tracking, they can often raise some sort of privacy concerns. And this is something that we will talk about more as we get into the details. In addition, this increased popularity of mobile health technologies, sometimes the platforms suffer from lack of established regulations, like at least in the US, the regulation on these things are still work in progress. And so this can be critical for patients as well. And so finally, there's this whole problem of, measurement of outcome. That's a non-trivial issue because of, self-selection, patient heterogeneity, and high dropout rates. So that's something to keep in mind that, this is not sort of a bed of roses. There's some challenges in user adoption, okay? So that being said, here's basically what we're trying to look at. We are essentially interested in examining the impact of the adoption of mobile health technologies on healthcare outcomes of patients with chronic diseases, okay? In particular, the outcomes we are interested in include their lifestyle and wellness behavior, as well as their hospital visits and medical expenses over time. And, more specifically in the context of healthcare, we are looking at, do we see any evidence that the adoption of mobile health can persuade patients with chronic diseases to make some sort of lifestyle changes, behavioral modifications? And if so, then what's the impact, the corresponding impact of those changes on their healthcare outcomes? Okay. So we're going to use a combination of experimental data and surveys to get access to all of this information. And after I walk you through some literature review, then I'll talk about the details of the experiment and what we got and how we got it. Okay. So let me, again, feel free to interject anytime anybody has any questions, and I'll myself try to stop every 5 or 6 slides. If anybody has any, something in mind, just let me know.
Just briefly.
Yeah.
I mean, my observation, I'm married to a physician, so I have an unusual perspective into this topic. Telehealth has really changed in the last 6 months because there was, some sense, many of the bottlenecks on the regulatory side just fell apart. The states gave in to a lot of things that they were holding back. Insurance companies also. Is your samples prior to that, or is it over that, or?
This is. Yeah, sorry. This is from a couple of years back. This was actually in collaboration with a set of companies in Asia. So this is well before the whole COVID crisis. Yeah.
Yeah. Oh, okay.
Okay. So let me just walk you through this. So here's the rest of the talk. So I'll give you some broad overview of the literature. There's a lot of literature. I probably won't be able to be exhaustive. So I'll give you some select examples of the streams that are related to this. Then we'll dive into the experimental setting, talk about the data and the model and the findings. Okay. So, there's a lot of work being done on the healthcare IT space that falls into the organizational perspective, where people have looked at, digital transformation of healthcare. And, like Shane was saying, this has been done well before all of this, telehealth. People have also looked at patient diagnosis and treatment. More recently, there's been a growing interest in the consumer perspective of healthcare IT. And some of these names here, Ritu Agrawal and Indra Burden, these guys have started to look at examining the impact of healthcare IT on patient care outcomes. So there's a work by Anderson, Agrawal, Burden, and Twain. Like, for example, the Burden et al. Paper looked at the chronic condition of congestive heart failure and examined the health IT usage in relation to visits in hospitals and readmissions. They found that the adoption of health IT is associated with the reduction in the readmission risk of these chronic heart failure patients. Interestingly, though, from our survey of the literature, the evidence thus far for the impact of healthcare IT on patient care outcomes is actually equivocal. But there's some prior research reporting either positive or negative or non-existent effects. And we believe to a large extent this is likely due to the limitation in the data deficiencies which obviously leads to limitations in the modeling that they can do. So nonetheless, we thought this is a interesting area to dive deep into, given that as opposed to using archival data, we do have a chance of randomizing experiment, which alleviates a lot of these concerns from the archival data analysis. Okay. So that's one stream of work. The other stream of work is broadly related to some recent work on mobile health and how it can change user behavior and adherence to medical treatments. So some of these studies have successfully piloted program based on mobile SMS. And in other words, the SMS is a channel through which messages are being sent, targeting patients with asthma and obesity and smoking, etc. So these papers that you see on the screen are some of these very interesting work. And they have found an impact from mobile SMS messaging on user health behavior. That said, it's the content and the delivery mode that seems to have an important influence on the effectiveness of these interventions. Okay.
Anindya?
Yeah.
One other, it's not probably going to be too relevant to your talk, but I would say there is a substantial regulatory literature on this also. And if I could just say, spending a lot of time in the U.S. regulatory environment, every single petition for favored status for multiple traffic lanes, if you will, like for high traffic lanes, high priority traffic lanes for wireless, and having multiple lanes. Every single one of those petitions uses heart monitors as their example. It is the most frequently cited example in the regulatory space. It's in fact, it becomes kind of silly if you sit there for a long time.
Right.
For what it's worth, and anyway, I just say there's an awful lot of this also in regulation.
Yeah, and we don't have either the data or the information to really sort of say anything meaningful about the regulations. So we're just going to try to confine ourselves to what we see about patients and their behavior and what implications it has for like the healthcare providers and hospitals. I think one can. I have to look at the work that you're talking about. I haven't looked at that yet, but maybe there's a connection with a reasonable leap of faith from what we are able to show for healthcare providers and the eventual regulations. But I have to take a look at that work first.
Yeah, diabetes will share a characteristic with heart monitors in that you want rapid feedback. You don't want.
Yeah. Okay.
Yeah.
Makes sense. Yeah.
Okay.
Okay, so like I said, I think our study, as opposed to all of these, our study focuses on healthcare centric outcomes like blood glucose and hospital visits and medical expenses, and we're also investigating various behavioral outcomes like number of steps you walk, the number of calories you consume, how many hours you sleep, that sort of thing. So these are the primary differences between what we do versus what has been done so far. Okay, so here's the context. We to evaluate the effectiveness of this mobile health app adoption on patient behavior and outcomes. Look, one could theoretically collect secondary app user data and examine the user behavior before and after. The problem, as I'm sure many of you realize with this, is with such an archival data model approach, you're going to get a strong self-selection bias, right? People who are users who care more about their health will be more likely to adopt the mobile health app and will more likely change their behavior and a lifestyle in a healthier direction. And so that self-selection would lead to some statistically significant correlation between the app adoption and the user health, but that's endogenous, right? So really, we want to avoid that, and that's why we went ahead and partnered with one of the largest mobile health platforms in Asia. They're in fact the largest in terms of specializing in diabetes care. And to give you some context, this platform has about 156,000 users, active users. They also have about 9,970 affiliated physicians who specialize in diabetes care across the nation. In addition to that external expert network, the platform also has a full-time internal expert team consisting of 20 medical professionals from like physicians, pharmacists, nurses, nutritionists, even psychologists. The platform essentially integrates all of these resources into one single app for patients. Okay, so you just get access to all of this through one app. Okay. So let me briefly talk about the core functions of the app. So there are 4 things that are relevant for patients. First of all, there's behavior tracking. This is where, and I'm going to show you some screenshots just to make it a little bit easier. So the first function is behavior tracking. Here, patients can record and upload at any time their blood glucose, blood pressure, what exercises have they done today, what's their diet been today, what's their weight, sleeping patterns, all of the behavioral stuff. Okay. The second interesting piece is the app also provides a risk assessment, like a personalized solution. This works the following way. There's basically a cloud-based backend analytics system that will analyze individual patients' data and then assess their real-time health risk for each patient by taking into consideration like 45 different kinds of medical conditions. What stage of diabetes, what's your type of diabetes, are you pregnant, are you a smoker, do you have comorbidities, all of that stuff. So based on that, the app will then recommend some sort of a personalized, risk score for you, as well as some, self-management solution regarding like, diets and exercise, etc. And to validate the recommendation, the internal medical team will actually review and discuss the analytic recommendation regularly to sort of, get feedback and improve the algorithm. Okay, so that's basically, it's sort of a combination of some individual human intervention from the experts, along with some back-end cloud-based machine learning algorithms. The third is Q&A. This is a more straightforward. Patients can contact the physicians either in the external or the internal network for suggestions on medication or treatment or self-management. And the last one is a patient community. This is where patients can talk to each other. They can participate in this community through the mobile app platform and discuss, whatever they have on mind. Okay, so any questions on the app features?
Anindya, could you clarify the country and the insurance environment? And
yeah, so this is based in China. Okay, so this is the largest, mobile health platform in China. They specialize in all sort of chronic diseases, and we are looking at diabetes. Did you say insurance?
Yeah, and I'm also curious, like how patients get access to it. Do they pay for it separately, or is it through the healthcare provider?
No, so in China, it's not. It's a combination. It's basically, there are some patients who will have some private insurance, but it's not as common as, let's say, over here. Okay? So there's a lot of, depending on the province, certain provinces, they have a top-down, government mandate that these are your choices for insurance, etc. Okay. Okay, here's some, just to give you an idea of what an app looks like. So the one on the left, this is an overview of the user homepage on the app. And you will see that, this is what the user sees after logging in, okay? And the one on the right is, you can see the blue button or the hyperlink. That's where you upload your, glucose value. And the dashboard will essentially, based on self-reported data about are you drinking, how often, are you smoking, etc. The dashboard will be continuously updated to give you some sort of a score. Okay. So this is what the initial homepage looks like. Okay. And there's a lot of detail. Yeah.
Sorry, what is self-reported and what is not? Are the steps the only thing that are tracked by a sensor?
That's right. Yeah. So the number of steps or the distance that you walk or run. So any activity that involves like walking or running in terms of distance is automatically gathered by the sensor in the app because it's on your phone. But the other activities like what food are you taking, what kind of exercise are you doing, okay? Those are self-reported. And what will happen is, in terms of the calories, once you report what kind of exercise you've done over duration, it will calculate calories. The same with diet. If you report the food and the portion that you've taken, it will report the food calories as well.
Yeah, thank you. There's some apps for which, like for example, for food, you can take a snapshot, you can take a picture of the item you're eating and automatically calculates things, so it may be more accurate. Is it something that this app does, or it's literally me writing what I've eaten?
So both. So here the users do have the option of taking a screenshot of the food they're eating and uploading it. At the time you were working with them, they had far more confidence on the former method, which is where the user actually, described what food they have taken and the portions, and then the system would calculate the calories. The second one, the automatic calculation of calories for the food, was in progress, and we saw some early data. The calibration was reasonable, I would say. I wouldn't say they were very accurate. Over the last couple of years, they've gotten to a level where we'll be comfortable with that level of calibration. So we have both the data sets with the picture and the textual description, but we're going to rely primarily on the textual description.
Got it. Thanks.
And so, I need diabetics. Do they check their actual glucose level by pricking? Do they do that?
That's correct. Yeah. So this is all self-prick. Like at that time, they didn't have. I think there was in 2019 there was a company in Israel that came up with this, a non-pricking method, right? But these guys were all doing it through self-reported self-pricking, and then we are basically cross-validating their self-reported data with a survey at the end of the treatment, just to make sure that they're not, reporting anything that's outrageous.
Right, but they do upload actual sugar levels that they actually test on themselves through pricking. Is that right?
That's right. Yes, that's right. Yeah.
So, Anindya, what is your sense on the accuracy of this data? So, in terms of people either misreporting on purpose or just forgetting to upload, to account for all the calories that they have eaten.
Right. So we feel pretty good about that, Hena, because what happens is every time the user uploads their data, we have someone from the internal medical team, verifying with them. Essentially, they will either call them or verify whether these numbers actually make sense. And so this was important, because otherwise, with medical trials, sometimes self-reporting can be problematic. So we had to make sure that there would be cross-validation through either a survey or a phone call. And the internal experts will do a combination of the two, to make sure that things actually make sense.
Excellent.
One more question to the patients here. Are they taking lots of medications? And one of the characteristics of other kinds of studies like this is that just getting people to take their medicine turns out to be a major improvement. It could not be diabetic, right? Here, it could be people who are taking things for their heart or their cholesterol or things that interact with the diabetes. So it could matter as well.
Yeah, I would say, I don't remember the top of my mind, but about 15 or 17, I forget, % of the patients had some comorbidities. So to the extent that, you have cholesterol and BP and sugar, I would say that, and people had anywhere from, at least what they reported, they had anywhere from 1 to 3 comorbidities, that's 17 or 20%. So yeah, I think some patients had, they had this habit of taking medicine because they have to, take medicine for the other diseases as well. Okay. All right. So that was, just some more screenshots of the app. Okay. So here's what the experiment looks like, right? So the first group is a control group. This is the baseline group, okay? They're not obviously being part of any treatment. They're reporting their glucose and hemoglobin levels independent of the app. They're just going directly to a web portal and uploading that, okay? Control group 2 is the second baseline that is examining the potential device. So this app that we worked, that the company created, had a web version for desktops and PCs, and they had a mobile version as well. And so our C2 is a control group. They have access to everything in the app, everything that the mobile guys have, except that they are part of the web group, the internet desktop group. Okay, so they have to do all of this on the desktop. This helps us, examine differences between mobile and desktop users. The first treatment group, this is our T1. They contain the regular mobile health app users who have access to, all the app functions. We also have 2 other treatment groups. The second treatment group was created to examine any synergistic effect between when the users are using a mobile health app and when they are sent a reminder, like an SMS message, okay? With sort of twice a week, they would be sent a generic or a personalized SMS message with general knowledge about diabetes, for instance. And I'm going to show you a couple of examples in the next slide. So we basically have 3 treatment groups, right? The first treatment group is just essentially using the mobile health app. The second one is using the mobile health app, but they're also getting a reminder, like a nudge. And the third one is getting a nudge, but that is slightly personalized. And maybe personalized is a little too strong, but essentially it will mention the name of the person and say, hey, dear Shane, today you didn't walk enough. Okay, so it's a reminder.
Anindya, quick question. So,
yeah.
And the treatments of the mHealth app, so I assume that I'm assuming the experiment is to encourage people to use it, not to force them to use it, so to speak. So
yeah. There's
what about the SMS and the mHealth? Because there will be people in treatments 1, 2, and 3 who do not use the app. So how do you get to personalize and then send them the SMS in the T3 example, for example?
No, so each of these treatment groups will basically have users who are using the app. Okay, so think about the first treatment group, the second, third, all of the users in these groups are using the app. Okay, the second and the third groups are getting a reminder in addition to their normal usage. They're getting like twice a week, bi-weekly reminder saying that, hey, you're not doing enough, or you're doing well. Does that clarify?
Maybe I didn't. So the thing is, how do you make sure that the randomized group uses the app? I'm missing some. I think I'm missing something there.
Oh, so yeah, I was going to say. So when we recruited, and in my next slide we'll talk about that. So we have an incentive system. So the way it works is, and maybe this is a good time to explain, right? So when we started designing the experiment, we recruited participants using the typical medical trial method. So in medical trials, what they do is they advertise on multiple avenues. So social media, social networks, hey, come, we're running an experiment, come join this. They also send flyers and posters to like hospitals and doctor clinics, etc. So we did all of that. And in addition to all of that, our flyers or the call for subjects had an incentive that if you participate in our experiment and essentially be a regular user of this app, then you will be eligible for a lottery in which you can win anywhere from $50 to $250 worth of products. And this was, people had the option of either choosing the cash option or like a Fitbit or an Apple Watch kind of an option, if they wanted. So that was the incentive, Eva. So and it had to be made clear that we only those guys who are continual users of the app would be eligible for the lottery. So if that being said, we did see a dropout, and I'll talk about that. We had about a 15% dropout, meaning that some people after a few days of downloading the app, they decided not to continue.
and just last one, but then what happens to C1, the non-treatment? So if I sign up because I wanted the lottery for using my app, now how do I end up in no treatment condition?
No, so when we described the experiment, you also told that this is an experiment, so some people will use the app, some will have to go to a separate portal to input their records, input the information, and even for C1, the incentive is still the same. If you on a regular basis, if you are uploading your data, then you'd be eligible for the same incentives.
Okay, thanks.
Okay. So this was, just to give you an example, and like I said, this is the generic message that does not mention the name of the person, dear diabetes, care advice, something like that. The second one is slightly more personalized. It says, dear Mr. blah, 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 you haven't been in your active self lately. And basically the idea is, yes, there's a little bit of personalization, but the message is the same as they would see on the app anyway. Okay, so you can almost think of these reminders as like a nudge, and we're trying to see if there's two things going on, right? First is by comparing T1 with C2 and C1, we can examine the effectiveness of adopting this this mobile health technology on user behavior. And the other thing is between T1 and the other two treatments, it tells us whether in addition to the app, would it help to have an additional reminder to encourage people to participate in this behavioral modification. So those are the two high-level sort of issues here.
So, Anindya, what type of outcomes will you be able to compare really control versus treatment? And what type of outcomes will you able to just measure within treatment across the different arms?
Yes. I'm going to get to that in 1 minute, Kira. I'll just finish talking about the, I guess I talked about most of this anyway, but I'll just repeat a few things I didn't mention. Then I'll get to your question right away. Okay. So just in terms of, how, like I said, we recruited participants for an experiment on a voluntary basis using a combination of channels, announcements in national websites, newspapers, social media, social networks, etc., as well as offline in hospitals and communities. And to ensure, the experiment was conducted on a rolling first come first serve basis, which is very common in medical trials. Some of these papers we rely on, Gupta et al. And Yuri et al. They follow the process. So overall, the recruitment period was about 7 months, from May 2015 to December 2015. And what we end up getting is that during the treatment period lasted for 3 months, 90 days, starting from the day of registration. Okay? So based on the random assignment to the experimental group, each participant received the corresponding treatment during that period. In addition to the patient level demographics and medical history that we got from the surveys, we are also able to get information on their hospital visits and medical costs. Okay? So to give you specifically, each participant was interviewed twice. Okay? First at the beginning of the experiment during the registration period, and then again they were interviewed 5 months after the last day of the treatment period. Okay? During the two phone interviews for the pre and the post treatment surveys, we asked the participants about demographics, medical history, most recent blood glucose and glycated hemoglobin levels, frequency of hospital visits, medical costs, etc. Okay, so I think this gets to your question, Kiara. So what information do we get and how? And tell me if this is not clear. I'm happy to just make sure that it's clear. Okay, so on the mobile health app, okay, we're going to get a panel data of individual health and behavior characteristics, starting from glucose value, glucose type, pre-breakfast, post-breakfast, pre-lunch, post-lunch, pre-dinner, post-dinner, etc. The uploading time and the date, the number of communication with the medical expert team, the number of steps. This is, I think you asked me that question, and the calories burned. Okay. In addition, we have the average time for the exercise and the average time for sleep, and other app-related activities like frequency of app daily usage, satisfaction rate of these patients, average calories per meal during the most recent 3 months, and so on. So the first few, where you'll see the first few are, it's a combination of, self-reported and automatic, right? So automatic is basically mostly the number of movement steps, calories burned. The others are self-reported, okay? So this is coming by the user inputting it directly in the app. In addition to that, we're getting information about the users through surveys, the pre-treatment survey and the post-treatment survey. Okay, this information consists of, again, you've got individual age group, gender, marital status, frequency of glucose monitoring, any comorbidities, what was the most recent glucose blood type, smoking and drinking, pregnant or not, any past or current medication, medical history, and that sort of thing. Okay. Okay, so I just want to make sure it's clear at what we are doing. Any questions on any of this? Okay, see a thumbs up. Okay, so first, we obviously want to make sure that these data actually makes sense. So across the 5 experimental groups, the first thing we'll do is we compare the distribution of the patient demographics and the baseline health conditions. And we found, as you'll see on the screen, that the distributions are similar across groups. Okay, so that was a good sort of sanity check. There's no, particular group that stands out, okay, one way or the other. The other thing we do is we also, to sort of better control for any potential patient level, variation in patient level characteristics, we also looked at, several models by testing only subsets of these variables, and I'll get to that in a second. Okay. But this is the first sort of, check for making sure that these groups are not systematically dissimilar in any way. The second thing is, I think, Eva, you had asked me this question, that are people continuously using it, right? And, so this is, the answer is no. We did find a dropout rate, okay? So the dropout rate, like I said, was about 15%. But one thing we had to do was, we had to make sure that to alleviate any concerns that the folks who are dropping out, again, systematically different, we compare their demographic and baseline health conditions between the guys who remain for the treatment period, the eligible sample, and the dropout sample. Okay, so basically a t-test, a Welch t-test. We could not reject the null hypothesis that there is no statistically significant difference between the two samples. And so this was again a useful check to make sure that people we are testing are not systematically different in any way.
Anindya, sorry.
Yeah.
So the dropout sample, are these people who were originally put into one of the treatment arms and then dropped out? Because if so, you can almost include them and have an effect on sort of intent to treat.
Yeah, so it's a good question here. So it turns out that, a lot of them, majority of these 15% dropped out within a week, just in the first week, okay? So because the treatment went on for about 3 months, right? So let's say, to your point, if the dropout was happening after a month or after 6 weeks, I think you would have enough sample to kind of look at intent to treat. But about 89% of that 15% dropped out within a week. So we didn't really get much to,
Quick question. At this stage, going into this field experiment, you kind of set the arms, you get the people in. Was your going in hypothesis that mobile will deliver better results, mobile with nudges will deliver even better results, and mobile with nudges that are personalized would deliver even better results than that? Was that your kind of going in hypothesis or not?
Yeah, so Ellie, you got 2 of the 3 right. So our hypothesis was indeed that mobile will do better than web, okay? and the reminders will actually do better than mobile alone. However, surprisingly, we found some interesting results that while the generic reminders tend to do better than mobile app alone, the personalized reminders often backfire. So in fact, not only are they less effective, so my next slide, it's a good segue, Ali, so I'll jump right into it.
Okay. But it seems like going in, one would have thought maybe that the personalized would do better, but then the result itself came out surprising.
Yeah, we were, and look, I think if you talk to some of the sociology experts, the theoretical guys, I mean, there's some literature we found that says that personalization doesn't always do better than, generic, okay? There are privacy concerns people have and all that. Most of that work, including some work we had done, was in the marketing context, in the advertising context. So I guess I have not seen anything in the healthcare context. So in some ways, that was a surprise that, the personalized reminders were, less effective than the generic ones, and sometimes even less than the mobile app alone. We did survey them afterwards, and I'll talk about the survey results. But most of them were about, people, even, I know this is not in the US, it's in Asia, but even there, people get concerned about too much information and too much potential privacy intrusion. Okay, so this was just to, before I get into we have a simple DID framework. Before I get into DID, I'll just talk you through the group mean analysis. This is what Ali was asking. So we have 4 metrics we care about. The immediate ones are glucose levels and hemoglobin levels, and the long-term ones are hospital visits and medical spending patterns. So take a look at, C1 is your, the baseline, C2 is the web versions, T1 is mobile only, T2 is mobile and generic reminder, and T3 is mobile and personalized. So as you will see, the most effective one is in fact T2, okay, in terms of reducing glucose levels and the hemoglobin levels. And, to Ellie's question, you will see that T3, the folks who are getting the personalized reminders are in fact, responding marginally less than the folks who are getting the generic ones, and even the folks who are not getting any reminders. Okay? So, yeah.
If you look at the last column, and maybe you're going to get there, but T3 reduces the expenditures so significantly. So maybe they're doing something outside of the app that you're not measuring.
Yeah, so we don't know. It's a good point. We don't know for sure, Kiara, right? So our speculation was the following: that so on one hand, T3 is not as good as T2 when it comes to reducing glucose and hemoglobin, but it's better than T2 when it comes to reducing hospital visits and spending patterns. So our theory was, the use of the app and the reminders in some ways is actually increasing the trust that they have with this ecosystem, with the healthcare platform, with the expert advice they're getting from the internal and the external networks. So it's like telehealth is better than going in person, So yeah. In other words, what our theory is that the increased usage of the app and the reminders is moving them towards adopting telehealth more and more and reducing their offline visits consequently.
Now I have a follow-up question, which is it good that they are reducing their hospital visits more because their glucose is not going down as much?
Yeah, so exactly. So I think, in the survey that we did in the post-treatment, right, we asked them about, well, if you're reducing the hospital visits, what about your, medical, the dosage and the symptoms? Are you complying with that? So the responses, said yes. I mean, we obviously, because we are replacing in-person visit with telehealth, we are, basically trying to make sure that we are in compliance with whatever treatments we are being told to, so we are taking out medicines for. But again, at the end of the day, we can only say what we observed during the 1.5 years, right? Maybe, if we had longer data, we could have a much more, concrete decision on is it necessarily good. At least in the short to medium term, it's good, like their expenditure is going down and so on.
Thanks.
Anindya, what are the units for these, both the glucose, the hemoglobin, and I guess the spending is USD. Is the glucose like the measured blood glucose percentage? Like what are the means of those numbers?
I'm not a super medical expert. This was this one, so mm per liter, Abhishek. That's what we're looking at.
What is the mean? So how should we just think about the percent effects?
Essentially, like, we're looking at before and after, right? So the drop that you see over here is what was the drop in glucose after they adopted the app for the 3 months versus before when they started. So if your let's say your blood glucose, the normal is, around 95 or 100, I forget, right? So anything over 105 is considered your borderline diabetic. So this is if it drops from 100 to the margin, whatever the marginal effect is. So the incremental marginal effect is what we're capturing.
It's about half a point, yeah.
Yeah.
And what is the mean spending in the 3 months? Like, how should I think about a $11 or $30 reduction?
So the means, yeah. So this is about 6 to 8% reduction in medical expenses based on their average, monthly or annual expenses.
Got it.
Okay, so our first module is, like I said, we will do a simple to count for individual level analysis. We're going to do this DID framework. Okay, so the first level difference is the within group glucose change over time. Okay, this is the group specific time trends. And the second level difference is the discrepancy in the time trend across groups. Okay. So like, I guess put more formally, we are modeling the glucose value for patient I at time t as follows. Treatment here represents indicators of the 5 groups. Time t represents the time indicator for how many days since the start of the time treatment when the corresponding glucose value is uploaded. So that's during the 90-day period. XIs, these are the control variables for all the patient-specific time invariant characteristics like age group, gender, income level, marital status, diabetes type, diabetes age, etc. And the CIs, this is a vector of controls for the patient-specific time varying characteristics such as the time of the day, morning, afternoon, evening, day of the week, the month indicators, glucose uploading activity, the uploaded glucose type, daily exercise, total steps, and so on and so forth. Okay. Okay, so the first module, this does not have patient fixed effects. I'll also show you the results with the patient fixed effects. Okay. So here, what we're looking at is the primary coefficient of interest is beta 3. Right? This is the vector that contains the coefficients for the 4 interaction treatment effects, treatment versus time. C1 gets dropped out, obviously, because of collinearity. And the first thing to notice is that all the 4 groups, C2, T1, T2, T3, they are experiencing a reduction in patient glucose values. Okay? So this is the finding that is telling us that, diabetes, the self-management platform, whether it's mobile or web, is effective compared to the baseline control group that did not use either the web or the mobile app. And then comparing T1 with C2, we see a significant device effect. So the mobile platform is in fact more effective than the web platform in reducing the glucose levels over time. Okay. Then third, you'll notice that when you compare T1, T2, T3, these are the 3 treatment groups, we do see an interesting trend, right? So T2, and this is to your question, Nelly, right? So the mobile health app with the non-personalized message is actually more effective in helping patients reduce their glucose levels over time compared to T3. This was also what we observed in the group level analysis, okay? And some of the prior literature on privacy versus personalization, like the Harley et al. Papers, the Free et al., Pop and Bishop, these guys had kind of theorized that, this is not unusual to see instances where personalization may not be as effective. And again, just to keep in mind, it's fairly limited personalization, right? In our context, it's essentially your name and whatever is your personalized risk assessment score that you anyway see, that's been shown to you. Okay, so this is the baseline model, okay, without the patient fixed effects. Another good thing you'll see here is that when you look at the baseline coefficients, right, the majority of the beta ones, look at the beta ones, none of them are statistically significant. So that's a nice finding. It further validates that the random group assignment, indicating that the initial glucose values don't seem to vary much across groups. Okay. So here's the first set of findings. Okay, so now we are going to I'm going to add patient level fixed effects because in the previous section we considered a large number of patient characteristics to control for individual level heterogeneity, but we're going to repeat that the DID with the patient level fixed effects. Here, the UI is capturing the patient fixed effect, and note that in this model, we are dropping the treatment indicator because that's correlated with the patient fixed effects. And so the primary coefficient of interest here is beta 2. Okay, this is the interaction between the treatment group indicator and time. Okay, and we're going to estimate the model with patient-specific time varying characteristics, and show you the results next. Okay, so overall, good news is that we're finding that this patient level fixed effects model is in fact consistent with our previous analysis using the treatment group level fixed effects. Okay, similar high level findings that the adoption of mobile T1, T2, T3 will statistically significantly improve the health outcomes of diabetes patients in reducing their glucose levels. Okay, even after you control for these individual effects. Also, you're seeing a consistent trend that the non-personalized mobile messaging is often, as a general guidance, is doing better for diabetes patients compared to the personalized messaging. Yeah. Okay. So, any questions so far? Okay. So next, I'll get into the specific behavioral modifications. Okay. So here we are interested in food, exercise, and sleep, right? So the previous result, right, this is broadly overall what's happening with glucose. Now we're looking at food, exercise, and sleep. So and the goal here is really we're trying to disentangle the underlying mechanism that drives the observed health outcome, right? So our theory is that as people adopt these mobile health apps, they are making changes in their lifestyle, which is then leading to changes in the glucose and hemoglobin, glycated hemoglobin level, right? That's the theory. So we're going to do it in two ways. We're going to do them separately first, which is what I'm doing now. And then last thing I'll talk to you about is like a simultaneous equation model. Okay, we're going to jointly estimate these two models, just as another sort of robustness check. So here we are looking at the second, at sort of the first step, right? Which is, are people in these treatment groups making changes in their food consumption patterns, exercise patterns, and sleep patterns? Okay. So what you see in this table is, and this one I'll show you one more table that, here, that again the T1, T2, T3, these effects are statistically significant with respect to food calories. Okay, so the more food you consume, sort of, the smaller is your change in glucose levels, whereas the more exercise you do in terms of time, or the more calories you spend in exercising, or the more you sleep, or the more you walk, those are positively affecting your changes in glucose, right? So more exercise and more sleep, you're better off with the lower glucose. And more food, more calories, obviously will go the other way around. Okay, so
Anindya?
Yeah.
So are you worried that there's strategic input of information into the app, which actually may be a function of being reminded. So I'm reminded that I should be good, and I tell you that I'm good. Well, in fact, you know, I'm behaving differently.
Absolutely. So in fact, you know, anytime when you have self-reported data of this kind, right, we have to be concerned about that. So, you know, like I was mentioning before, the one thing and perhaps the only thing we can rely on is, you know, the post-treatment interviews and the surveys that the medical experts do with the patients. We made sure that they interviewed or surveyed every single patient in our sample, okay? And just to sort of cross-validate that whatever they have been reporting is not inconsistent with what they will say in the survey or the interview. Okay?
Got it.
So that was, you know, the best sort of a comfort level that we could do.
I think the fact that the steps go in the same direction and steps is sort of a fixed quantity that they cannot really manipulate is very comforting.
Yeah, that's a good point. You know, like we are basically, you can say that the automatic data cannot be manipulated, right? So if the rest of the data is headed in the same direction, you know, it seems to bode well, I guess, for us.
Yeah.
Another question. So maybe you're going there. You know, I don't object to doing this because this is the natural first thing to do. But in some sense, you're burying a question, which is those with more comorbidities have higher incentive to. I mean, they have more reasons to be complacent or to not be complacent. Right? On the other hand, they may have been. I could go both ways with this. Before you start the experience, they're also the people who are most aware, and so they're the least likely to change because they're already behaving well in what Chiara says. You know, they had nowhere to go, but because they were already doing well. But I could go the other way. They have the more reason once they get the reminders to you know, exercise and to do the calories appropriately and so on. So I really want you to split the sample or to take into account some of that heterogeneity, which at the moment, I understand why you're not doing that in the way you specified it, but you know, I'm very uncomfortable with that because I want, there's a very natural difference in incentives between the most sick and the least sick. So.
No, that's a good suggestion, Shane. I'm just jotting down that idea. We haven't done that. We can definitely do that. Yeah. You know, we have, like I said, you know, we have, I think 17 or 19% of patients had one or more comorbidities. So that's a good idea. I'll make a note of it. We can definitely
it'll push your data a little bit because it's not.
Yeah, definitely. Yeah. Thank you. Yeah. Okay, so if there's you know, nothing further on this, then just to sort of extend this, you know, discussion. We, you know, here obviously we have the patient level fixed effect. We're looking at, you know, similar things. And again, overall, I mean, you know, there's obviously a lot going on over here, but overall, look, the broad trends are consistent, right? So T1, T2, T3 are all, you know, statistically significant for the first 5 markers. T2 tends to do better than T1 or T3 in most of these instances. And so it is essentially saying, look, broadly, we are saying that there is a device effect, mobile versus PC, number one. And this is, in fact, encouraging people to do higher, you know, more daily exercises, consuming healthier food with lower daily calories, walking more steps, and sleeping longer for the day. We had also broken this down into just, you know, daily calories from breakfast, lunch, and dinner, you know, small subsample analysis. And overall, when you're combining the mobile health app with the personalized messaging, it is leading to about a 33% decrease in the number of walking steps and about a 28% decrease in total exercise time. Okay, so the qualitative nature of the results remains very similar. Basically, you know, it is at least telling us that highly personalized messages may not always work well in trying to persuade, you know, patient behavior modifications. Okay.
Yeah. Speaking of those personalized messages, I still can see two hypotheses for explaining this lack of an effect, or a smaller effect than the non-personalized message. One is that I'm really put off by the fact that you're tracking me so much, and so it's really a privacy concern, or which is sort of the standard hypothesis. The other one, which I don't know whether you're able to evaluate this, but maybe the personalized messages were wrong. So like you're telling me that I haven't been as active, but actually, no, I have. And so there's some mistakes in the algorithms that make it such that the personalized messages are actually less precise. And I don't know whether you can disentangle these two.
Yeah, no, great point. The second one, we in fact did that, and I'll explain in a minute how, right? So two things happen. One is in the post-treatment surveys and the interviews, when these medical experts are reaching out to each of these, 1,100 patients and asking them, we asked them about the reason why they were not responding as well, right? So the majority of them said privacy. We did not see people complaining or saying that the messages were inaccurate, but we didn't want to rely on that alone. So what we did is, for every day that a patient actually saw the text message with a personalized message saying, "Hey, you did not walk more than 45 minutes a day," we corroborated that with the internal data that we were calculating in terms of steps or calories lost. Okay. So in other words, we employed some independent coders to check the accuracy between the message they're getting and the internal app generated data. Okay. Yeah. So no concerns came up on that front.
I mean, it could be an issue it's related to privacy, but the personalized message, because of their nature, they almost feel like criticism. Oh, you've not been doing this enough. Oh, you haven't been. Oh, you're eating too much. So it feels like a negative reinforcement, and that sort of triggers an aversion or a reactance rather than something general.
Great, Eddie, excellent. In fact, one of the survey response, when we probed further into the privacy issue, they said, "You guys are judging us. We don't want to be judged." Okay, so I think that did come out in the survey. Okay, and it's not unlike that survey that was conducted in Japan, where when the government asked people that, "Hey, do you want immigrants or robots?" Because of the demographic dividends, people in Japan said, "Well, we want robots. We don't want immigrants. So immigrants will judge us." So it has that flavor. Right?
Yeah, I mean, I wonder what would have happened if you had a T4. Where it's about, when they do something good, it reinforces, oh, great, you've been walking a lot, keep it up. So it's kind of like a positive reinforcement instead of a negative. I wonder if it would have had the, a better effect than what you're getting with T3, just a curiosity out of that. Yeah.
So to some extent, Eddie, so one thing to note is not all the personalized messages are negative, because it's really a function of what you're doing and what's being captured in the app. So for instance, let's say you're actually a very, conscientious, in terms of exercising and eating, then your app will give you a very low risk assessment score. And so the message that will be shown to you is actually positive. It will say, "Eddie, you're doing great. Just keep walking the regular 20 minutes that you do." Okay. Whereas if I am like the opposite, I'm very lazy, not very conscientious, then I will get that negative message. "Hey, you've not done enough." And so maybe I wasn't clear, but so the personalization can go either way. The sentiment can be positive or negative. Okay, so so I think here we obviously added all the other controls, and even with the fixed effects, these results are consistent with the previous set of results, as well as with the group level results. Okay. So a couple of other, quick things, like I said, so far, we have examined these effects separately, and we just want to sort of try to close the loop as much as possible. So what we did is we also jointly estimated this question using a simultaneous equation model, right? So the first equation is testing the impact of treatment on exercise, and the second equation is testing the effect of treatment on glucose, okay? And we did that with both glucose, with exercise and food. So here you will see that, more exercise is leading to a drop in glucose, which is what you would expect. So all the treatments are positive. So again, T1, T2, T3 has a positive effect on inducing people to exercise. So that's good. And T2 is more than T1 and T3. And, that's like, think about step one. Step two is having exercise more. Those guys who are spending more calories are seeing a drop in glucose. Okay. And then we also did the same with food. Again, now the sign is the opposite, because obviously the more you consume, the more your glucose. Again, the three treatment groups have, the expected effect on food. So if you are part of T1, T2, T3, you will consume less food. That's a good thing. And then consequently, based on your food intake, your glucose will actually go up. If you're consuming more food, you're likely to experience an increase in glucose. Okay. So again, this was just to clarify. We did this. We also did a DAG, a directed acyclic graph approach. This is more of a computer science thing. Some of you probably know this very well. Basic idea is, rather than the econometric models were helping us look at these two separately. We just tried our best to close the loop here and say, look, the simultaneous equation model is helping us close that loop, but also the DAG. The DAG method is pretty common in medical trials, and some of you are probably familiar with this. It's just another kind of a mediation analysis. Okay? It's also further supporting this causal impact of mobile health adoption on health outcomes through the mediation effect of this patient behavioral change. Okay, so a couple of last few things to talk about. Like I said, after the treatment, we also did a bunch of surveys and interviews. And this is just to give you some more color on what's going on in their mind, like what worked and what didn't work. And what people liked about this, learning about the health knowledge, real-time tracking, personalized diabetes assessment, all of that. Then we looked at, in addition to the survey responses, we also conducted the pretty in-depth phone interviews with the randomly selected group of these participants. The main purpose of the interview was to further verify the survey, right? So we're just trying to, remove as many sources of discrepancy as possible. So we got the experiment and the app data, then we have the survey, and then we have the interview. So in the interviews, when we asked participants whether they like the personalized medical guidance or not, and majority of them said that they found it too frequent, too annoying, violating privacy, and sort of this judging, you're judging us. In fact, I remember one of the participants explicitly mentioned that we are being judged all the time by someone, and this is not what we appreciate. But again, this is, we can only say so much about what's going on. A couple of other checks, because we had a long recruitment window, we also reran the analysis within the specific months when they were recruited and treated, just so that there is any less potential confounding factors over a longer period. So that worked out fine. For instance, we looked at the month of May only. You were recruited then and you treated then. And many of you asked me this question, did you do any validity checks for the self-reported data? Like I said, the internal medical expert team helped us review and validated the information from the experimental participants during that period. In particular, as part of the risk assessment function, the medical team communicated with each patient, mostly through phone calls, to carefully go over the historic records and the corresponding algorithm-generated scores to explain them, validate the results. This validity check was done for all the patients in C2, T1, T2, T3. And for the patients in C1 who did not have access to app, we had these guys validate their self-reported information during the surveys. Okay. In particular, during the phone calls, we went through their self-reported glucose values with them and validated their answers in person. Okay, so that brings me to the summary slide. So yeah, I think we are happy to sort of see evidence that mobile health adoption is in fact causing a reduction in some chronic disease outcomes like glucose levels. The underlying behavioral mechanism is essentially changes in patient modification, so exercise, food, sleeping patterns, etc. Some more good news from a slightly longer perspective. We are seeing reduction in hospital visits and reduction in medical expenses. Obviously, the caveat is, we can only say so much about whether this is a long-term good or not. To your question, Kiara, we expect it to be okay, at least for a while. And as long as patients are complying with their, medication and treatments, it should end up being okay. From a platform design perspective, it was interesting and useful to see that mobile is more effective than web, quite strongly, in fact. And sort of the last design issue of the platform is that we shouldn't probably have a blanket personalization policy for reminders. It seems that there are some nuances we have to keep in mind. But I think I personally think there's a lot more work that can be done and probably should be done to further dig deep into this role of personalization versus non-personalization. I think we could only scratch the tip of the iceberg here. So I think we have got a couple of managerial implications. I think there's some evidence that we can use these wearable devices and mobile health apps for self-management. We think we are seeing evidence that patients are complying with this, at least for the short to medium term, with diet changes and lifestyle changes. And there is some medium-term implications for healthcare providers when we see that people are able to use telehealth to replace in-person, and then they will reduce hospital visits and medical costs. So that's pretty much all I had to say for this.
Cool. That was awesome.
Thank you.
Can you hang for some questions for a little while?
Yeah, sure. I think I'm happy to answer anything.
Yeah, so here I'll start with one. So the personalization can take a couple different dimensions. It can take the dimension of how, because people differ, there are tall people and short people, and so that gets fixed early on, and then the personalization can take into account some characteristic that's fixed like that. Then there's also personalization in the sense of dynamic, what's changed over time. And personalization could take into account behavior last week, as opposed to this week. And then those two can interact as well, right? Hey, we know that tall people ought to be more cognizant of what they did last week. You're right. So it seems like the personalization story here, in some sense, doesn't go that as far as it could go. And I was sort of struck by that. It seemed, at some level, the personalization side here put their name in there, and
oh, sorry.
Yeah, that was it. It doesn't seem like it goes as far as it could go.
Yeah, definitely. I think like I said, I think I liked how you differentiated that into static and dynamic. And as I'm writing the paper, it didn't occur to me, but some of that, we can do. So for instance, in our personalized reminder, we have the name, which is static.
Yeah.
And we have the, hey, you didn't exercise enough, or you did very good, right? So that is dynamic.
Oh, yeah, fair enough. Yeah.
So, but I liked how the framework about static and dynamic. I think I'm going to, use that in the paper as well to sort of, position the messaging a little better. But to your larger point, yes, we have done something fairly limited so far. We have the only static thing is the name. We haven't talked about age or, height or anything like that. And the dynamics are probably a little more richer because we have all of the, behavioral data from which we are generating the personalized message. But yeah, I like that, the way of framing that personalization piece into a static and dynamic. And, so Baby and I were talking, we have a couple more ideas we want to pursue with these guys. They seem to be open to it. So I think, we are interested in pushing more on this space. So one thing we would want to look at is, more richer aspects of personalization and see how does that induce any behavioral change and how long do these effects last.
Yeah, totally fascinating. Yeah. There's one other dimension to personalization, which is sort of beyond what you can do, which is the interactive dimension. That you send an email to your doctor and they respond, or a text, and so you get a very unique communication going. I guess you have a little bit of that here because you do have these doctors on the other end.
Yeah, like during the telehealth that these guys do, right? So they have like this app and the platform. They have 20 internal experts, medical experts. So that's where the telehealth comes from. There's also the larger network of doctors. The app is affiliated with 9,900 doctors. So I think we can certainly start to look at more telehealth aspects as well. Like this was like the first step towards figuring out, does any of this even matter? And now that we see, yes, it matters, I think, we are thinking through some of these other, trying to get deeper inside personalization, telehealth, and see what we can do.
Actually, Shane's question made me sort of think of a follow-up question, which is, you could in principle look at whether these patients actually interacted with doctors through the app, right? So you've seen a reduction in hospital visits and you've seen a reduction in medical expenses. Is it because they substitute away from offline towards these online means? So are they messaging doctors? Are they talking, looking for advice on these doctors? And that really will sort of give support to your hypothesis that they are actually considering telehealth as a substitute for their traditional way of getting health advice.
No, thank you. That's a great idea. We can absolutely do that. In fact, we have, the not only the frequency of communication, but also, the content. Anytime it was not a phone call, it was a text or an app-based message. We have all of that, and we can definitely look at the sample of people who are sending these messages to the internal doctors and see if they are the ones who are more likely to, drop out. That's a great idea. Thanks.
Yeah, can you see Q&A too, whether they use the Q&A feature? Because, because I mean, it's self-help in a way. If the kind of question they wanted an answer to is easier to find in this environment, maybe they don't need that.
No, absolutely, Shane. We know the Q&A, the content of the Q&A, and again the frequency and all that. So I think we can definitely do what you guys suggested.
Kiara said it's great.
Thanks. This is a good idea. I think this will further. I didn't think
a separate paper. In my mind, this is a completely separate paper. It's really substitution between offline and online, and you use the same experiment to look at that different question. I'm always torn about like whether the second paper will have enough of its own, but your ideas are definitely spot on. We can do all of this, and whether it's in this one or in a follow one, we'll have to figure it out. But thank you. This is great.
Anindya, you have a patient community component to your platform. I don't think you reported any data on the use of the patient platform to communicate with other patients, did you?
Oh, hey, John, good to see you. Yeah, so, we, in our controls, we have, those very granular controls, how often are people using different features of the app, not just how often are they logging in, but, we have these 4 features. So we added controls for like how often are they using the risk assessment feature or the patient community feature or the Q&A feature. We also have the content of the communication, anything that they make public in the community, we have access to that.
Okay, well, look, in a more proactive way, in following on Shane's point about interaction, it's often struck me that communities, these would be communities of people who don't know each other, right? There'd be So there's no way of knowing whether an inbound communication from the community is real or virtual. And it's conceivable that an inbound communication from a fellow sufferer, who in fact doesn't exist, might set up some kind of either collaboration or competition within the community, and that particularly the competitive dimension, as we've seen with things like Peloton and so on, can be quite a provocation for not only for communicating but also for participating. Just a thought.
Yeah. So one thing we have done is that, every participant who is part of this, they have been, if I got your question right, you're thinking about what if some of those guys who are actually not real, they're just, bots, right?
Right.
So we've been able to validate every participant using their phone number.
No, I don't mean it in a negative sense. I mean it as a proactive. So the first order of business would be to have members of the community work with other members of the community to create enthusiasm. I'm not suggesting anybody's a bot, but the members of the community provide incentives, collaboration for others to participate. Okay. And then secondly, since that can't be controlled, what about having virtual community members who deliver controlled messages to test the general effect of community interaction?
Yeah, that's a good point, interesting point, because I think, we can say something about that because, we are able to observe not only when patients are talking with doctors, but also when patients are talking with patients, because, we have this online community. Mm-hmm. And I think to some extent, just piggybacking on Chen and Kiara's suggestion, again, if those patients who are talking to each other, are we seeing any changes in their hospital visits and their sort of, drop in medical expenses? Then we can say something even more strongly about how telehealth is replacing, in person. And again, to some extent, this is all pre-COVID, I guess. So that's good news because, I think the effect of telehealth in COVID is, there's a very strong COVID effect, right, in telehealth. But if this is from, a few years back, 2016, so in some ways, if we see that telehealth was beginning to at least replace some aspect of in-person consultation, then it's more likely to be, that transformation will be expedited post-COVID, right?
Mm-hmm. Yeah. That's awesome.
Yeah.
Well, I'm going to meet with you later, Anindya. So I'm happy to see conversation to others.
All right. Well, thank you so much for all your comments. I know a couple of guys just texted they had to leave, but I'll see, some of you later on.